Financial health is a vital sign. We have an exciting hour plan, a very robust discussion that we're really excited to have here momentarily. But before we jump in, I just want to take this moment to acknowledge and thank our sponsors for making Policy Consortium happen: Bristol Myers Squibb, Johnson & Johnson, Lilly, and Vertex. And we're also required to include this disclaimer, which really only indicates that the opinions expressed by our speakers today do not reflect our opinions here at National Patient Advocate Foundation or Patient Advocate Foundation, but we are absolutely thrilled to include as many perspectives here as possible. And as I mentioned, we have quite the speakers lined up today, including Becky Barnes, who is from National Patient Advocate Foundation, a volunteer who has been with us for many, many years. Sam Becknel, who is an expert by experience with Patient Insight Institute, and Erin Prendergast with the National Association for Community Health Centers. And many of you may know already Rebekah Angove and Rebekah Kirch, Rebekah Kirch will be facilitating the discussion later on. But at this time, I'm gonna pass it over to Becky Barnes to open the forum today. And we, again, just thank you all for being a part of this discussion. We will have a Q&A a little later on in the hour, but please feel free to add any of your questions to the Q&A prompt here on your Zoom menu bar. But Becky, please take it away.
Melissa, thanks so much for the introduction. Again, my name is Becky Barnes. I'm a volunteer advisor here at the National Patient Advocate Foundation, and I'm also a patient, and I live in Eastern Kentucky and have to travel for care to Louisville, which is about a 2-hour trip. And there are some financial hardships that go along with that now, because at the hospital that I go to at the University of Louisville Brown Cancer Center, they are no longer allowing people to use insurance to do telehealth. They are not doing telehealth anymore. And so that means if I have a appointment that maybe lasts 15 minutes to go over lab results or imaging, things like that, that I would have to take a day off work. If I have my caregiver to drive me, they would have to take a day off work. And then we'd have to travel there, the gas, and all the time that it takes for a 10 or 15 minute appointment, which is really hard on a lot of people. And coming from Eastern Kentucky, where there's a lot of poverty, it does create a large, hardship for them, because the cost of care is much more than just the insurance or co-insurance. And, that's just what I'd like to say about how it can happen for a patient and the hardships that they go through, even if they do have insurance.
Thank you, Becky, so much. And we treasure the many years of dedicated service that you've brought to the National Patient Advocate Foundation. It's just, our base of volunteers are such an incredible force for change, for good, and for community. And being in Kentucky, it's one of the real places on the ground where access is really in jeopardy. So we're very grateful for what you bring to this table today. I'm Rebekah Kirch with the National Patient Advocate Foundation. I lead the policy work that we do. And I have a couple just scene-setting slides to include. I'm celebrating my 10-year anniversary of the NPAF right now, which is startling in some ways. It seems like yesterday I started it, and at the same time I've also been at this for a good long while, doing policy for now 30 years. But something I think probably rings true for everyone, and we welcome you if you're new to NPAF joining us today, but also our old friends and partners, we welcome you back, and we're so grateful to have you here. This is a time of renewing strength behind the belief system that I believe all people who are patient advocates and caregiver advocates have, in terms of putting people first. Patients and caregivers are people primarily who are undergoing all sorts of different challenges based on the health conditions and the health system that we have today. And it's certainly an objective that we make sure that everyone has access to healthcare without experiencing the distress that financial hardship can cause. So one of the unifying factors for us at NPAF is the priority that we place on putting patients and caregivers in the rooms of influence where change can happen. That includes the research system, that includes health policy system, it includes insurance design, all these different places where quality measures get built. We want to make sure that authentic voices like Becky Barnes that you just heard from are placed in the rooms to help bring the authentic real world perspectives of people. And that's some of the research that my colleague Rebekah Angove is going to bring forward today. But the last point I'll make, just as a scene setter, the floor, if you will, for our conversation today, is that we know intrinsically, but the health system hasn't yet adapted to understand that physical health, mental and behavioral health, and financial health, you can't tease those apart. We all walk around as people with all of those challenges, experiences, and needs in our heads. And so today's discussion sort of has this as the backdrop. And I see, and I'm so grateful folks are carrying on the habit. Do introduce yourselves in the chat where you're from and who you are. We're so delighted to have that information to carry through. Next slide, Melissa. I did a little research over the last 2 days. This is my livelihood, to have to keep track, the finger on the pulse of what the headlines are saying. And on any given day, it can be 16 or 18 or 20 assaults to what healthcare costs are looking like, the implications for patients, families, loved ones. And we just illustrative here of some of the stuff that we know just from the past 2 weeks around the challenges we're going to be facing with helping people understand what the Medicaid work requirements will be when they don't even know that they're happening, that out-of-pocket costs are looming very large in the context of healthcare and everyday life for all of us, and that affordability is something that's very much on people's minds in terms of daily practice, the decisions they make about the care that they get or don't, or ration or put off. And opportunities for us to come together in forums like this, I think, are very important to sort of pull together the community that we all bring and the shared objective and really work of the heart to make the health system work for all of us and what that's going to mean. So we'll launch into the discussion with the next slide, and I'll introduce colleague Erin as part of this. One of the things we know responsive to the healthcare cost challenges and the fact that it's really not been built into the health system yet, we called this financial health as a vital sign because we need to give the financial health a priority on par with what we're doing with other aspects of medical care and what people tell us they want. And we ask them notoriously early and often, patients and caregivers, they want help to ease their cost concerns. This is a priority for them. It's something that we know matters a great deal. And within Patient Advocate Foundation Direct Patient Services, we have case management that helps do some of this. It inspired the agenda that we've built around needs navigation, alongside the incredible work that community health centers and the workers within them, the practitioners do, that Erin will talk about. The 1-2 punch that it's helpful to have as the backdrop for today is that needs navigation, helping ease cost concerns with hands-on support by steering people to and through using resources that are available. And a lot of those resources are the safety net. So we have to make sure that we're doing all we can and joining forces to protect the safety net, which includes community health centers, includes Medicaid, includes SNAP. So many local community resources are part of the safety net as well. But on the federal level, we're really focused there on how can we surround with a strategy of protection for every setting, every person, and every single case. So with that backdrop, I'm so delighted to welcome Erin Prendergast to our table of Policy Consortium to tell us about the innovators that community health centers have been for patients and families hardest hit by financial hardship, but also a great model for all the rest of us in thinking about how do we bring needs navigation everywhere. Erin, join us, please, and thank you so much for being here.
Yeah, thank you for the opportunity, Rebecca. As mentioned, my name is Erin Prendergast, Director of Federal Policy at the National Association for Community Health Centers. Thank you all for saying hi in the chat and where you're joining us from. It's been great to see some representation from New Jersey, where I'm from, DC, Virginia. And I think Rebecca said it, set the landscape well of just it's so alarming just to know that our healthcare system, as folks navigate it, the price and the financial cost is always in the back of the mind for any encounter for healthcare. And so, really excited and just to engage with you all and just share where health centers really fit in this conversation and how we're navigating that. And I see some health centers, El Centro in the chat. So some of this, may be familiar, but wanted to take a moment on the next slide to just do another level set on HR1 and just really the changes that are occurring on yes, thank you, for Medicaid enrollment eligibility and the marketplace. And so I know there's been, a lot of news and summaries being out there, but at a high level, all these Medicaid enrollment changes are really putting so much more work on states to verify and implement enrollment processes. These more frequent checks and the documentation that's going to take is really, unfortunately, could result in faster coverage loss. States are also just feeling a financial squeeze as well from these changes of really ensuring that any Medicaid or enrollment is, accurate. And, earlier too, at the end of last year, a lot of conversation on those tax credits to help engage beneficiaries through the marketplace across the country, and just knowing how vital those were, and just to see those not be renewed. And then marketplace of just, that's not, always a solution for losing Medicaid coverage, but just knowing that that is potentially another option for coverage. So just knowing there's so many changes occurring across the board. And so on the next slide, talking about where health centers fit in on outreach and enrollment, and really how this is so core to the health center mission and the expectations of health centers as well. So there's a lot of text on the slide, but really the goal I wanted to share here is on the left side, the health center movement was, put in statute through Section 330 on the Public Health Service Act. And within that language, you can see in the highlighted text in yellow is that health centers are, are required or expected to provide patient case management services, really to help establish eligibility for gaining access to federal, state, and local programs that provide or financially support the provision of medical, social, housing, education, and other related services. So a lot of those community services, those networks, that really is a foundation to the health center movement. So it's really reassuring to know that that language is in law. Additionally, the services that health centers are expected to, provide is to enable individuals to use services within the health center, and then really educating patients and the general community on what is available within the health center. Health centers have oversight from a federal agency for the Health Resources Services and Administration, and they just go further to say that health centers are required to have staff that are available to assist consumers or members of the community with enrollment in Medicaid, CHIP, and marketplace coverage. Really performing enrollment assistance on behalf of the health center through, volunteers or contracted individuals, really making sure that that training is made available to them, but it could come in many different forms within your local community health center. And just having them on site and making them available to the community. So really great foundation that can be learned on how health centers approach really making sure that members of the communities and individuals have that connection to healthcare coverage. On the next slide, taking a step back on, as I just covered, it's defined in law through the Public Health Service Act for health centers. But ultimately, these, connections and enrollment services is really to increase access to affordable coverage and care, really address those preventative and timely services. From a healthcare, from the provider perspective, it's also a step for financial sustainability for services within their health centers and making sure that they are able to continue and support, their sliding fee scales and allowing people to pay, what they can. As I mentioned, it's really core to the health center mission to really provide outreach and enrollment activities. And it really has allowed health centers to establish trust within their communities of being able to help people navigate complicated systems, whether that's county-based or state-based, and the multi-level steps to gain access, and ultimately improves patient care to be able to have that reassurance that there's coverage to access the services that they need. On the next slide, so again, looking at how this may look in a health center is just understanding, insurance options could be one way with one-on-ones from the health center staff, enabling services with an individual, creating user accounts and updating those accounts, filing an exemption or an appeal based on what information may come back to a beneficiary through the state. Understanding the different healthcare coverage options that are available for an individual and really providing that unbiased perspective of what the options are for an individual or family. And then, selecting the right plan within the marketplace that meets their needs and submitting those applications to the marketplace. On the next slide, really just to see this in scale from health center perspective of just that hands-on, like personal connection. This is not, there's some opportunities for automated assistance, but really this is a personal connection. And health centers are really great leaders in being able to establish that. And so there's many different ways that they may have this team approach. And so we see outreach workers, eligibility assisters, but ultimately this is data from 2024. And so together nationally, they were able to provide 4.9, almost nearly 5 million assists. And then the professionals that provide these services are just over 31,000 across the country. So really a good partnership to eligibility work as well. On the next slide, as we talk about, financial health and really being a vital condition, I just wanted to share this slide on how NAC is really approaching, what we know as social drivers of knowing how healthcare is really impacted outside the walls of a healthcare provider. And just our approach of really understanding to move that to really an understanding of vital conditions of someone's health and well-being. So more information on our website to engage, but really just wanted to share the framework that we are taking this approach on vital conditions of patients within health centers. And then on the next slide, one pathway and tool that we do or have to really understand these vital conditions is through our Prepare tool. Very long acronym, but it really is a screener that health centers can use to understand some core, vital signs for our patients. And so really helpful for health centers to understand where to take actionable direction and, evidence-based approaches to addressing, concerns that may come through this screening tool, like housing stability, transportation, housing status. Those are all opportunities. This screening tool allows health centers to be able to zone in and really help patients connect to services that they need most immediately. And then lastly, just wanted to say thank you to the workforce that provides such this personal connection and really to achieve, access to care. The health center community provides 52 million care to 52 million active patients. This is done by over 326,000 community health center staff. So that's clinical, administrative, all levels of care, to over 16 million Medicaid enrollees and over 6 million uninsured individuals. So really just important work that health centers are doing just to continue to make sure that communities have access to the essential services that they have. So with that kind of overview and foundation, I'd love to turn it back to Rebekah to continue our conversation today.
All right, I can pick it up from here. For those of you that don't know me, I'm Rebekah Angove. I'm Chief Science Officer of Patient Advocate Foundation and the Executive Director of our Patient Insight Institute. I'm going to bring you a little bit of a different presentation today. So our job over at the Insight Institute is really to help build an evidence base to push conversations and policies and support what we're hearing from patients every day, like the discussions we're going to have today. The evidence and the reason that we want to bring more voices in is because we want to show that this is a pervasive problem. This is something that everybody should be talking about. And if you ask people, this is not, we didn't just cherry pick the three people that think this is a challenge or a problem. This is something that we think everybody should be talking about. And a lot of patients have a lot of perspectives on it. And so we try at the Institute to collect all of those and build an evidence base for all the work that NPF is trying to do. So what we did for this event today is a little bit different. We sat around and we talked to patients. It's considered qualitative data. It is still research. It's just a little bit different than all the numbers and the figures and the statistics. And so I just have a few slides to set us up for, I think, a really interesting and robust conversation that's going to come next. The first thing we did is we asked patients, what do you feel? What do you think? What's the first word that comes to mind when you think about healthcare? And this is a word cloud. The bigger the words, the more times people actually said it in our listening sessions. And so there is a lot of challenges in healthcare. There is a lot that patients are going through, both financially and emotionally. So this is, this is hard stuff, complicated, stressful, barriers, deductibles, dread. I mean, this is a pretty loaded word cloud. You can go ahead and go to the next slide. So in these conversations with patients, we got a little deeper, and what we found is that there is this link to access, between access and affordability. So patients are feeling financially overwhelmed. They're at the same time, they're feeling unsupported, and they've really lost trust in the system. When we ask them, they trust their doctors, but the system as a whole, they just don't feel like the system is built or is doing a good job of helping them. And asking for help is really hard. You can see this quote about asking for help. There's a huge stigma. And so that's something else that I think we need to address, that not only do we need to make sure that the help is there and people that can help, but we need to reduce that stigma so people feel comfortable asking for help and getting the help they need. Go ahead and go to the next slide. So we specifically asked about some words. We did a little bit of what's called cognitive testing around some of this vocabulary. So how people really understand, identify, and feel about some of the words that we use a lot in healthcare. Safety net was one of them, and people generally had a positive feeling about safety net, but there was still that stigma around needing support. And the safety net is really that kind of that bigger, broader network of people that, we talk about them, prevent them from falling through the cracks, and hence the word net. And you can see a few of the quotes on the side. I'm sure our discussion will mirror that, but there are financial safety nets, there are emotional safety nets, communities can serve as safety nets. And I think the one thing that I want to bring up to the surface here is that as more patients need these safety net services, the safety net's actually getting thinner, and there are less services and resources for patients to access, and that's a growing challenge. All right, next slide. So the other term we asked about was social services, and we had a lot of different opinions about the use of this word. Was it good? Was it bad? Not surprising, but it is fun to see it written on a slide, right? Written on paper, that the perception of social services is experience driven. Those with negative experiences feel negative about this term. Those with positive experiences feel positive about this term and this type of help. And again, it feels obvious when you see it on paper, but it's not something that has come out before, we really sat down and talked to our group of patients. All right, we can move on. I'm trying to give everybody a minute to read the quotes. I am not a fan of reading what is on a slide, but I want you to see the actual words of our patients because I think they are important. So we talked about financial hardship with patients in these listening sessions in these groups. And patients had a lot to say about this. It was easy for them to define this term. They understood what it meant. They had extensive experience in financial hardship. One of the things that has come up for years since I've been doing this work is this idea that if I say something about my financial hardship, my ability to pay, the fact that I may not, whatever it is, my income, my insurance, patients really worry that they are not going to get the best care, optimal care. They think it's going to affect the quality of the care they receive. And patients also really feel like sometimes this term is tied to their identity. They don't want to be seen as somebody, or somebody that, is financial hardship. Maybe they're going through something, but that isn't the core of their identity. And there was a lot of conversation around that, right? Like, I'm more than just this financial hardship I'm going through because of a diagnosis, because of circumstances. So again, it raises that stigma that we really need to address if we want people to get the help that they need. All right, next slide. All right, affordability, and these were all terms, right? We got into these groups and we said, talk to us about this word that we use all the time, that you hear all the time. And really what we found, and I love this quote, it's more difficult than it should be for any of us at this point, right? I feel like that just sums up what I would like to say about everything that we heard. And people really feel like they're not getting the help that they need. And we heard people say, if I got the help they need, if I could afford this, I wouldn't care if you put financial distress or affordability in my chart because I would be able to afford care. People are just exacerbated at trying to navigate to get their care and then not being able to afford it. Again, nothing surprising to this audience, but when you see it in black and white, it I think validates some people's experience, and it's really eye-opening for others that maybe don't realize how big of a problem this is for everyday people. And then the next slide, we asked about access, and access is tightly tied to affordability. I won't get too deep into it, but it's this idea of, if I had more money, if I had more resources, I would have access, right? So for most of the patients we talk to, access could not be separated from affordability. If I could afford to take off work, I wouldn't have access issues. If I could afford hotel rooms to sleep over because I had to go so far for my care, I wouldn't have access issues, right? So we do know that we want to expand and extend access for patients, but when you talk to patients, these two things are tightly coupled, and I don't think we can address one without the other. All right, we're getting to the end. I promise. This is all to just set us up for a really great conversation. We also wanted to talk to patients about financial health, the positive side of this. We always talk about financial distress and financial toxicity and all of the negative terms. And so we asked patients, what does financial health and wellness look like? And this was really, really hard for patients to even answer. A lot of it was just an emotional response. Patients don't want to rely on others, on support systems, on their friends and family for loans, all the ways that patients are cobbling together ways to afford care. They just talked about financial health as being not having an additional stressor to getting the care that they need, right? They said financial health would just be not having to worry about how I'm going to pay for care, only having to focus on getting care, getting well, getting the treatment I need, and not having that additional stress of finances and cost. And for a lot of our patients, it feels out of reach. It feels like something they're never ever going to achieve. And I think that's something that concept of hope is something we don't talk about a lot, but we're seeing it a lot, and it ties tightly into this idea that full wellness, full care, healthcare is physical health, emotional health, and financial health, and those are all tightly tied together. All right, and then, yep, next slide. We talked to them about what good help looks like. When you go to somebody, when you're brave enough, when you said, you know what, I need help, and even though I might feel nervous, stigmatized, scared to ask for help, when you finally get to that point, what does that look like? And we heard all of these things from our patients. This is the type of person they want to help them. Somebody that's educated and trained, somebody that's empathetic. They're informed, they understand, the financial aspects, the medical aspects, and a lot of the social aspects. Somebody that's caring and supportive, and somebody that's really willing to go above and beyond. I know at PAF, we have case managers that will, help people get forms signed, right? Like send them out paper copies and bring them back, go in and be on a call with somebody. So they're coaching them within a call, right? Like those things, patients don't just want a handout of phone numbers to call. And then, a few quotes at the bottom, but really this idea of patients also need to know that there's help out there, and they need to trust that help, those people that are there to help them, can get them connected to the services they need. So we had a few results from our cognitive testing. This is, what is the term? Do patients understand it? Do they not? Is there kind of positive or negative connotations? What other descriptors are patients using when they talk about this, and where can we find the common definition? I'm going to leave this here. I'm sure everybody on the call will be going back and watching this recording. You can pause it here and read this whole slide. I'm not going to go through every piece of this, but this is kind of the structure of what we did and what we found. And I've gone through many of these points in previous slides. And with that, I am actually going to hand it back over to Rebekah, because I think the most exciting piece of the event is about to happen, where we get to have a discussion.
And it's so fun that we have three Rebeccas as part of this discussion, the panels, together with Erin, and we'll welcome Sam as well. I'm struck. Thank you, Erin and Rebekah and Becky, for setting us up for this conversation. I'm struck how much financial hardship is so easy to detail, and the financial health is aspirational at best, right? This isn't an us-them problem anymore, and we can bang the pots and pans all we like to complain about the rising costs of healthcare and the injustice of it. And in fact, we have to do that. But it also has to be tied to solutions. We can't just complain about the water's too cold. We need to dive in and say, here's some practical proven solutions. And we've heard about them in the context of how community health centers are already doing this incredible work to assess and address people's financial needs. Not honoring it in the breach, but making it a prominent part of the upfront conversation. And that's where needs navigation and how we talk about it, Patient Advocate Foundation with case management, community health centers, and many social workers in hospital settings, in nursing homes, are trying by hook or by crook to be able to make this possible. But we need to create a scaled solution that's sustainable and a safety net that's robust enough to have resources to support people's needs. Rebekah mentioned this. We can't get there if the safety net continues to shrink back. Erin mentioned this as well. We are all reliant on Medicaid, on community health centers, on SNAP, on many different resources that address the social drivers that are causing people's challenges. So I'll invite the whole group to be here for the conversation and welcome Sam, who I hope you'll introduce yourself first, one of our experts by experience. I'd love, Sam, for you to kick us off and telling us, because you were a participant in this research that the Patient Insight Institute did as one of our experts by experience. Anything that you want to call out by what Rebekah talked about or Erin presented, or even how Becky opened things in terms of what you've seen?
Well, thank you, Rebekah. And like you said, there's so many Rebeccas. Thank you, all the Rebeccas. And Erin, I mean, I appreciate your presentation as well. I mean, the data is just on point. So I am excited about this conversation because not only that I feel like I'm an expert by experience, but also I parlay that with years of my experience working in health policy on various projects over the years with Robert Wood Johnson funded programs and CDC and the American Heart Association. So these conversations have been going on in all types of ways over the years for a long time. But I just, I think what just resonated the most with me was talking about this navigating healthcare systems and how daunting that could be, and thinking about my own experience going through that. But then the excitement of the fact that, and it's probably, not fair because I have so much experience working in those systems, but to see how you can actually, as an individual patient, navigate some things yourself and be your own advocate and force some of the systems to do the things that they have to do for you. So I'm just excited that, thank God, there was a marketplace plan for me. Thank God I had a good healthcare provider when I had various ailments that referred me to specialties, and my plan actually helped me get through that. And I just can't imagine that if it was someone who was a novice and don't know things that I know, how daunting it would be for them, and they would feel incapacitated and not do anything. And so I would think when, Rebekah, when you talk about scaling and solutions, you're talking about actually the patient themselves becoming advocates for themselves. And if we can figure out a way to do that and scale that, I think we got something sustainable.
Thank you, Sam. And that's where Becky Barnes is such a great example of the network of advocates and the family that we've built, right, Becky, in terms of joining forces to think about how can we as patients and caregivers drive the demand alongside partners in health centers, Erin's contingency, and the other partners who are all really focused on tackling this cost concern problem alongside the the myriad problems that we have with the health system today. But there is optimism, isn't there, Becky, that there's opportunity to join forces, not just bang the pots and pans, but drive solutions like needs navigation as a care model? How are you feeling about that?
Yeah, I agree with that. I think that I have a positive outlook on those things because I see that there's not just talk, but there are people who are actually taking action. So it's so good to have these conversations, but to know that like after we leave these conversations, that there's actually, things that are being done behind the scenes and in the front, and especially just, coming out of school and everything and working with different nonprofits and things of that nature, and seeing more nonprofits actually working together is like, it really gives me hope. And so all of the things where people take their real life experience and, they're working with nonprofits and they actually have a voice to speak. And I think that the real life experience is what makes the difference.
We're really hoping, every crisis can breed opportunity. That's certainly how policy typically advances, right? And as we face down, Erin, what you described in your slide deck, the challenges looming with Medicaid cuts across the board, what do you see as the biggest opportunity for the patient community to work together with your provider community in terms of raising awareness about what needs to be done and the opportunities we have to work together?
Yeah, I think the opportunities from health centers is with patients is to, have that strong line of communication, that bi-directional of, patients are, if they are the ones that are engaging with enrollment systems, whether that's, online or just through their agencies, of what is the barriers and what's the problems. A lot of feedback we can share at local and state, policymakers is like call wait times or navigating those assistants when we know like maybe there's certain languages that are not being made available, or there's faults with kind of in the menu of service of options. Like sometimes people can get stuck in that cycle, and hearing that feedback from patients of just where they're getting tripped up in terms of trying to get support to submit documentation or complete applications, like that's really invaluable insight for health centers to then be able to, one, help patients navigate that, whether they have a direct contact or try to problem solve right away, but also to be able to relay that information, as many of them sit in different coalitions at their community, local and state level, to really understand how to best implement these changes that are coming.
Thank you. I think we certainly stand ready at National Patient Advocate Foundation to think about how can we help support what patients, caregivers, and professionals need to understand the shift in Medicaid work requirements, in the medical frailty exception, what enrollment will look like and eligibility will look like, as just one example of pressing ahead with action, as Sam emphasized, the importance of action here. And we have action intended. I think we did also create some cheat sheets that I want to make sure I know our team is ready to drop in the chat. A box set of issue briefs, and the latest one captures some of the quotes and the research top line findings that Rebekah Angove shared. So we'll be sure to drop those in it's a trilogy of 3 really series that we've built into Policy Consortium this year. I have a dog whining in the background. A trilogy of 3 that focus on the cost spikes, the needs navigation as an essential aspect of care, and an intervention. Again, if we don't have versions of case management available to help people, that hands-on support that each of the quotes Rebekah featured, I don't know there's help available. Or if there is, I don't know how to get it. Then that's our job, to make sure that case management happens in every healthcare setting, not just on occasion, or if you're lucky, that it's a standard of care. And I think that's the policy conversation. And it's elegant and simple, yet very challenging in this environment to advance a new care model that would have to be accepted as a condition of participation ultimately before I retire. That's my dream. Where Medicare and Medicaid recognize, and commercial insurance, that without this base of hands-on support for people to find their way through the financial concerns, just like they have help navigating the clinical concerns, we haven't done our job fully yet. And Rebekah, as we think about the next phase of research, you hit on it in your slide toward the end about what makes good help or a good navigator, a needs navigator. Can you talk a little bit about the next phase of research in terms of us identifying the attributes and how we plan to do that?
Yeah, I'm so glad you came back to me. So we're talking about action, right? But then I always need to make a plug for evidence, because we need to really keep collecting data. And I hate using the word data because it sounds so impersonal, but really data is just many, many, many tiny stories lumped together to show the impact and how pervasive some of these challenges are. So we really need to keep understanding what these policies mean, the real life effects they have on people, and then what the identified solutions are. And I say identified solutions from patients, right? So a patient-centered approach to these solutions, not what politicians think we need to do, not what healthcare systems think we need to do. They've been putting these solutions together and it hasn't worked. So absolutely, our next phase, we started to understand what the landscape looks like for patients and caregivers. We have started to understand, how patients are thinking about financial health and feeling about some of the language that we're using around that idea of access and affordability. We did a little bit, which I shared in the slides, around kind of what good help looks like. So, right, what navigation might look like, and we want to go deeper there. So the next piece of this is really understand from a patient and caregiver perspective what this help looks like, not just the attributes of the people, not who is delivering it, but how it's being delivered. And then I think when we do that, we can also identify what gaps are out there, right? So what are we doing currently that's working? What are we doing that is not working? And then what do patients really want that they are not finding? So a lot of those attributes and factors that needs navigation needs to incorporate into a model. I think about this like the minimum viable product, right? We absolutely know that spitting out a sheet of paper with phone numbers is not needs navigation. We know that. It's not what patients want. It's an okay first step. It's better than nothing, maybe. But we also hear patients that it kind of isn't better than nothing because now I feel completely diminished. I don't feel heard. I feel like this is just a throwaway problem. Here's a piece of paper. Look, we solved it. So it might be doing more harm. And I think, digging into some of that to really understand, okay, here's all the things we're hearing, right, in the ecosystem and in sessions like this. And, when we're talking to patients, now let's really do the research where we can put the meat on the bones of what is this going to look like, because we want this to be something that is offered to every single patient. We want this to be something that works for every patient, that destigmatizes the need for help, makes patients comfortable and excited even to receive care. I mean, I say excited. I wish we didn't have to get needs navigation, right? Like I wish there was no need in our system, but currently until we completely re-engineer the system, I think we're going to need needs navigation. And so that my long way of saying that's kind of the next step for our research, is to really dig in and understand what that looks like, what patients and caregivers want, and then also how that can actually fit into the current healthcare system. So it's not just developed in a vacuum. We have to make sure that these things are reasonable and able to be delivered somewhere within the healthcare ecosystem, and identifying where those sweet spots are as well.
I so appreciate that approach, because we do have good models in community health centers, in social work offices, yet often it's not the priority of the different care settings. And I know, Becky, part of the inspiration for you pursuing your scholastic career has been pressing on this need. What is it that your experience was that made you say, I want to be one of the ones that does this kind of work, needs navigation, et cetera, in my community? What inspired you?
Well, it goes back, very, very, I got into advocacy because my sister was diagnosed with cancer in 2001 when she was 18. And I was her stem cell donor in 2004. She passed away 2005 when she was 22. But my grandfather, when I was 4, that was one of my first memories. He was diagnosed with lung cancer that had metastasized to his brain. And I remember him being sick. I remember going to the hospital and seeing him there. And then back then in Eastern Kentucky, the doctor would come to your home. And I remember like when they were told that, he was terminal. And then at 12 years old, my best friend died due to complications from a brain tumor. So in Eastern Kentucky, cancer is, it's a very high rate there. And then after all of this, I ended up getting an autoimmune condition called Graves' disease. And of course, if you have one autoimmune disease, I'm sure anyone that has that know that it can typically come with more. You usually don't have just one. And so with that, coming from Eastern Kentucky, living in Lexington, which is a bigger city, and trying to find the best healthcare possible, I saw that there was such a need for advocacy for patients because we do have a healthcare shortage with our doctors and our nurses. And there are patients that are complex. They don't fit in a box that when you go to school to get your degree that fit in what the textbook tells you what people are. And so because of all of these, real life experiences that I've had, and then being a patient advocate for other people in these areas, I just see a need for that. A lot of people don't understand medical jargon. They need plain language. A lot of people, like I said before, they may have insurance, but if you don't have the means to get to your doctor's appointment, it doesn't really matter. And if you're someone who has, say, multiple myeloma and you have to be on oral chemotherapy medication for the rest of your life and you can't afford all of it, if you just take it one time today and one time next week because you're just trying to, be able to have some medication, it's not going to work the same. So in order for that to happen, when people go in and they get these diagnoses, they feel as if, it's a lot to take on. They may not even remember the conversation with their provider. And so with an advocate with them, they'll be able to know how to go into that before they even go to the doctor's office and what they need to do after. And that's so important. So we have social workers, we have people that are patient advocates, needs navigators. There's many different words that we use for a similar, responsibility, for these people. And that's kind of what got me there and keeps me going. And of course, I have, my own chronic illnesses. And I feel like because I'm in the doctor's office so often, because I get to talk to people from many different places, that it gives me kind of a unique experience that other people may not have.
And Rebekah, I think, and if I can just add something, I think the panel, this group that you've put together here is so fantastic because it really shows how it takes everybody to solve this problem and to talk about this problem for different areas. So, we have a patient advocate, we have, the kind of community clinical perspective with Erin. Sam, who I work with closely on our Experts by Experience group, where I know he has somewhat of a policy background, but he also advises on social need, social care, and biomedical research projects for the Patient Insight Institute, right? So that expertise to bring in to make sure that the work that's being done to further some of this, the evidence being done is patient informed and community informed is so important as well. So that I just want to highlight that before we end today, that this isn't every stakeholder we need, but the diversity of the stakeholders, we all have to work together, to build towards these solutions. And I think, we've done a really good, you and your team at MPAF has done a really good job of making sure the right people and the right voices are in the room.
I appreciate everyone's perspectives, and the importance of the policy is not lost on me in terms of getting this right. An innovative policy that isn't built based on CPT codes and co-pays and fee for service. This is about embedding a service as a standard of care in every care setting as a scalable solution in the spirit of value-based care and accountable care. These are jargon words, but they matter a great deal in health policy for us to get it right and to be patient-driven and coalition forced, I think is really critical in this case. I know we may have some questions which we'll get to, but Sam, I'd love for you to weigh in with a little bit of the last word because you are our action guy, and it's true. This is just talk without action, and capturing people's story is data. That Rebekah will help us to shape into a campaign. But I'd love to hear your thoughts on this conversation and the next steps.
Great.
Close us out.
I really appreciate listening to all of the presentations and all of the discussion. And I wish that the 100 or so other people who are here, we had a forum by which they can actually give some of their perspective, because like you said, all of us have to get involved. But, we have done this before. This is not unusual where we are. For example, when the tobacco companies just was ravaging our communities with tobacco and giving it to kids, we went out and got the master settlement agreement. When we got tired of people not being able to afford health care, and there was thousands of people that wasn't on health care anymore, we did the marketplace health care plans. So we actually really know what to do in multiple areas. We just have to like get on the ground and start figuring out ways to get some of these nonprofit organizations to start addressing these issues. Healthcare should be there should be nonprofit organizations cropping up all over the place in the communities related to healthcare, because it's a serious financial issue where, I'm saying I would not have been able to handle having to have a stent in my heart or having to have a cervical spine operation if it wasn't for me having a healthcare plan and people helping me to navigate how to pay for it. So I'm expert. Can you imagine someone who don't have my knowledge and what they're going through? And there's a lot more of them. There's 80% of them out there. And so I just think that we have to go back to grassroots advocacy and get on the ground and start cropping up stuff and stop sitting around acting like we shocked about what's going on. We actually know what to do. That's my message to this group.
I'll make a shameless plug that joining National Patient Advocate Foundation's grassroots network is that community of patients and caregivers who are more than ready and amped up, and we will be providing those tools. I want to turn it to Melissa, both if there are any questions, but importantly to close us out with our take action steps. And I'm so grateful to all of you. Thank you. Melissa?
Yes, I think there was just one question that I flagged that I thought you could touch on. I think you kind of did a little bit, Rebekah, but maybe you can expand a little more. The question is, could someone speak a little bit more about goals in the legislative or regulatory nexus? And so I thought that would be a really good opportunity given the presentation both Erin provided and the work we're doing with needs navigation. So I'll let you answer.
That's great. And I'll be quick because I don't want to shortchange your time to do the call to action. Legislatively and regulatory hand in glove, raising awareness about the need for needs navigation, which includes medical debt legislation already happening, surprise medical billing legislation already happening. So we are, of course, supporting that. But on the regulatory side, and we'll be having a specific regulatory webinar this summer, National Patient Advocate Foundation, to explain the influence you can have in that environment, which is different from legislative, but equally, if not sometimes more influential. We want to build a care model to bring to the regulators that are, in this case, the Center for Medicare and Medicaid Services, to understand the aspects of what a needs navigation care model would look like to include in all of the value-based care initiatives that they're doing. It's the Innovation Center. So that's our ultimate dream, with the research-backed patient stories that we can collectively work on together with the community health centers, who are the national highway system of healthcare for people who are under-resourced and needing what we're talking about. So it's a 1-2 push, and also protecting, again, the safety net and funding for it.
Thank you, Rebekah. I will close us out, but I also just want to thank the panel that has been assembled here and everyone who could be here to attend and witness this conversation. We know it's, we're here talking, and now we move to the action, right? As one of the main takeaways from this conversation. So let me bring up my screen. All right, so next steps, we will share the recording of this session as well as the issue briefs, which have been dropped into the chat. The latest one is called Financial Health is a Vital Sign. That really sums up a lot of the research that Rebekah Angove presented earlier. The second piece that we will do is and this really hinges on the what we hear from you in terms of your stories, is we will use your stories to influence policy advocacy and help make a lot of what Rebekah just talked about in terms of the policy and regulatory work that needs to be happening. We will use your stories to influence the work that we do there. But immediately following this session, we would love for you to just complete an evaluation so that we know how to improve for next time. And then we also invite you, if you aren't already a part of our grassroots network, as Rebekah mentioned, that really is our community, that force for change, that voice for change. And Becky can probably speak to it better than almost anybody in terms of just the community and family that we've been able to build in making sure that we just keep moving that needle forward. Sam, you said it so well. Grassroots advocacy is where it's at. And it really all starts with sharing your stories too. So I'm going to close by leaving this slide up. The QR link or QR code, I'm sorry, takes you to a Boast link where you can securely share your story with us. And that will allow us to sort of go through this library of different stories and use that to help influence, again, that policy work that we are doing that's really rooted in the voices that, and your perspectives that you all bring to this important work. So thank you all again to our speakers, to those of you listening. Thank you so much for being a part of this conversation. We look forward to seeing you next time. Thank you all.